Okay, thank you for the introduction and for hosting me again. I guess people think I'm pretty lucky that I get to go to Australia every year for my research, so I do have a pretty cushy job, to be fair. And Megan has told you that we've been working on this project for the last sort of 18 months or so. That will give you an idea of the complexity and the challenges with doing qualitative systematic reviews. And this is particularly of interest to me because this is work that, well, Joe and I have been doing for a long period of time back in a different institution in the UK about 7 or 8 years ago, maybe when we first started out doing Smokefree Homes work. So this particular review is looking at the barriers, motivators and enablers of smoke-free homes. And it's not just Megan, Joe and I that are working on this, we've got some other colleagues as well. So Jude Robinson, who's at Liverpool in the UK, and John Wiggers, who's at the University of Newcastle over here. So some of you may well be familiar with some of the smoking statistics, but I thought I'd just start off with a little recap. And smoking is the leading cause of premature mortality globally, and it causes 6 million premature deaths annually. And about 10%, so 600,000 of those deaths aren't due to direct smoking, but they're actually due to exposure to secondhand smoke. And this slide just shows you the number of people who are exposed, or regularly exposed to secondhand smoke every year. So it's about 40% of children, 35% of non-smoking females, and about 33% of non-smoking males. So actually, the proportion of people globally who are exposed to secondhand smoke is actually really quite high. Now, the health effects of exposure to secondhand smoke are really well established now, and I'm not going to give you a list of the health effects, but what I thought I'd do is look at the kind of the disease burden of secondhand smoke. And it's estimated to cause 10.9 million disability-adjusted life years, or DALYs, which you might be more familiar with, lost every year, and that equates to 0.7% of the total global disease burden each year. So we know that there is no safe level of exposure to secondhand smoke, and that's why we need effective tobacco control policies to actually help protect those that are at risk. And one of those policies is actually smoke-free legislation. So Australia are pretty high up on the tobacco control kind of pioneers, but this particular slide just shows you on the left-hand side, we're looking at jurisdictions that have got some form of smoke-free legislation. Now, I know that smoke-free legislation varies, and it depends. Different kind of jurisdictions have enacted different laws and slightly different kind of enforcement of that. But typically, it's about protecting people in public spaces, particularly workplaces or in hospitality venues such as bars. And on the left are jurisdictions with smoke-free legislation, and that covers about 15% of the global population are protected by those laws and legislation, which means that their main sources of exposure are actually in homes and in cars. But if we look on the right-hand side of this slide, these are the jurisdictions without smoke-free legislation, and that's 85%. Of the global population. So that's a lot of people who don't have any form of protection from smoke-free legislation. And their main sources of exposure are in workplaces and in homes. But what this actually shows you is sort of irrespective to some extent of whether you've got smoke-free legislation or not. One of the main sources of exposure for non-smokers is private homes. So what do we know about home smoking and smoke-free homes? Obviously, the best thing we can do after getting people to stop smoking is to promote smoke-free homes, and the prevalence of smoke-free homes is increasing. And when I'm talking about a smoke-free home, I mean that nobody smokes in that house, not even by a window or a door, at any time, and that rule or restriction is never broken. So the prevalence is increasing, so in the United States and in the UK, for example, we know that more and more people are having smoke-free homes or reporting that they've got a smoke-free home. And as that prevalence of adult smoking comes down, the number of smoke-free homes is increasing. But having said that, the evidence also shows that lots of people don't have a smoke-free home. And as you might imagine, the more smokers there are in any one household, the less likely they are to actually have a smoke-free home. And even in homes where they self-report that it's smoke-free, we know from the evidence base that non-smokers, particularly children, are still exposed in those homes. And that is because people's idea of what a smoke-free home is varies. So some people might think that they've got a smoke-free home because they smoke by the window or they have the back door open, but actually that isn't, or in our view, it isn't actually a smoke-free home, and the risks to the other people that are in that household are still there, and those kind of harm reduction strategies that are employed aren't effective. It's only effective if you go right outside of the house and close all the windows and the doors. So there has been quite a bit of work to date that has looked at the qualitative evidence base, which explores perspectives on an experience around creating and maintaining a smoke-free home. And we know that some people are really successful at this. They make a decision, they make their home smoke-free, and they're able to maintain it. And no matter what happens, those rules are rigid, and they do that, and they don't have any problem with that. But the evidence base also shows that some people find it really difficult, and they face quite significant barriers to making their home smoke-free and maintaining that in the long term. And this evidence base has, to some extent, tried to unpick what the reasons are for success and what the reasons are for those barriers and how we might overcome them. But to date, these multiple qualitative studies have been done in a number of different locations, in a number of different contexts, but nobody's yet synthesised that evidence to see if we can bring it all together and learn from that from a wider database. So why is it that we might want to synthesise this evidence base? So the synthesis will allow us to identify and translate things that are the same between those different studies, and also identify what might be different, and that's specifically looking at the barriers, motivators and enablers. Syntheses help you to arrive at higher order explanations. So it's not just about describing what's in each of those studies, but also to think more globally about what's in there and what we can do. And it also helps, a bit like quantitative systematic reviews do and meta-analyses, to provide robust evidence to help inform healthcare policy and decision making. And this is something that we were really interested in. How can we use this evidence base to help inform policy going forward? So that's what we did. We set out to do a systematic review and a thematic synthesis of that qualitative evidence base around smoke-free homes. And we had two main review questions. So the first one was to look at what are the barriers to and enablers and motivators of initiating and maintaining a smoke-free home. And then what we wanted to do was to look if those categories actually differ by context. So when I talk about context, I mean the study location. Do they have smoke-free legislation in place in that area? Is it that they're culturally very different? So, for example, the Chinese setting might be very different to the UK setting. And that's really interesting, and that kind of analysis, or Joe's been doing a lot of that analysis. I haven't got time to go into lots of detail about that today, so I'm going to focus mainly on the first question. But if you're interested in that particularly, then do ask us about that. We conducted, I say we, that's the royal we, Joe conducted a systematic search, I've upset everybody now, for relevant qualitative and mixed methods peer review publications in English. We did put publication filter on that because of how much has changed kind of in tobacco control policies in recent decades, so that's why we started at 1990. We searched 8 health-related databases, and we also did quite a lot of supplementary searching. We know that qualitative studies are not indexed very well. They're quite often hard to find. If you just do a quick search in Medline, you might not come across them. So we did things like we hand-searched 9 key tobacco and sociological journals that we thought these papers might be published in. We looked at PhD and MSc theses. We did conference abstracts that we followed up with authors to see if they'd been published. And then we looked at the reference lists of papers that we'd found to see whether we could actually identify anything that was missing. There were 2 phases of extraction, so 2 slightly different bits of data that we wanted. We developed a pro forma to extract summary data about the studies because we wanted to be able to, in the review, report what those papers were. So we collected things like where the study was located, who the participants were, how they were recruited. So that was what we extracted in the summary study pro forma for each of the included studies. And we also needed to extract the results and discussions and finding, however that was named in the paper, because in some qualitative work they're blended together, the results and discussion might be blended together. And we extracted that from each of the papers, and then we imported that into a specialist software called NVivo so that we could manage that. As you can imagine, from 22 papers, there was a huge amount of data to manage in this. We also critically appraised using a modified qualitative CAS each of the studies that were included. I'm not going to go into a huge amount of detail about how exactly we've done the thematic synthesis, but if you're interested, we followed broadly the methodology of Thomas and Harden, and at the end of the presentation, all the references are listed, so you can go away and look at that if you wanted to. But basically what we did when we got the papers was we looked at 8 papers independently, the 3 of us, and developed a code book from that, and it was done iteratively. So we developed a code book, looked at the next paper, see what new codes we needed to add, and then once we'd got the final code book, we applied that across all of the papers. And then from that helped us to interpret the key themes, and some of which I'm going to present to you today. So this just gives you an idea of a kind of the volume of records that we have looked at as part of our search. So at the top, these are the records that we identified, so over 6,200. We've looked at, and then we went through this standard kind of screening of titles and abstracts, and we looked at 69 full texts, of which 22 we took into the synthesis. So this just gives you an idea of where the papers actually came from, and you can see that predominantly they are from developed Western countries, and we've got 2 from China. So we had 4 in Australia, 3 in Canada, 2 in China, 10 from the UK. We're really into Smokefree Homes work in the UK, I think that's what that tells you, and 3 from the USA. So 22 articles in total, and they came from 18 different studies. So there were some papers that published more than one article on one particular study database, but we included them as long as they asked a slightly different research question as part of the analysis. And this covers 646 participants in total, the vast majority of which were caregivers to children, and there are a small number of healthcare professionals. They took part in 58 focus groups, 474 interviews, 2 expert panels, which is the link to the healthcare professionals, and then one of the Chinese studies had some observations, but they didn't report particularly well what they were. So they are in there, but we're not really sure what happened with those. And while you wouldn't normally kind of rate a CASP, we actually decided that we were going to rank them based on their findings from the CASP into high and low quality, and 14 of them we decided were methodologically reported as high quality. At this point, it's probably quite important to give you some context about what these papers actually are. And whilst we didn't set out particularly to look at the experiences of home smoking behaviours per se, it was the smoke-free homes bit we were particularly interested in. Lots of the papers talk about home smoking behaviours, and actually that's important when we think about the results and placing those in context. So what the papers show is that home smoking restrictions vary, as you might imagine. So if you think about it as a continuum, right from smoke literally everywhere in the house, all the way up to a complete smoking ban where no smoking ever happens inside, and then there's lots of kind of marks all the way along that, so you get this real variation. So that might be that we don't smoke around the children, we only smoke in 1 or 2 particular rooms, 2, I only smoke by the window or by the back door up through to a complete smoking ban. There was also some variation in understanding of what a smoke-free home is, and this is what I was saying to you earlier on. So we picked out a quote for you from one of the papers. So this is P is participant and I is interviewer. So this participant says, I don't smoke. I haven't smoked in my house for about 4 years. So the interviewer says to her, so where do you go? So she says, outside. Or I lock myself in the bathroom and open the window. So if you were, as a researcher, saying, oh, you know, she says, I don't smoke anywhere in the house. If you hadn't asked that probing question about, well, where do you go, you would have taken that, or I would have at face value. in the early days, I know that that's not true now, that this person didn't smoke at home. And it was only that probing that allowed you to unpick that actually she thinks she's got a smoke-free home, but the reality is that she doesn't. We also found that home smoking restrictions are really fluid, and this is something that came out of an early paper that Joe and I wrote a number of years ago, that pretty much all the people I've ever talked to, I know that the context might be different in other places, have some form of restriction. It might not be effective, but they will report some form of restriction. For example, in the UK, people very rarely smoke in children's bedrooms. I know that might not work in other places where children don't have their own bedrooms or they sleep with parents, whatever. But all the families I've talked to, they never smoke in the children's bedrooms. But what we find is that they've got rules, but those rules change depending on what's going on. So visitors might come, which means that they have a smoke-free home until visitors come, and then they start smoking with their friends. It might be that the weather's really bad, and they don't want to go outside. The UK weather is pretty bad, so that might be good for the UK. But they might not want to go outside. So there's things that impact the rigidity of those rules. We also thought I'd say a little bit about the smoke-free policy context. So Joe went and looked to see, at the time of data collection, whether that particular jurisdiction where that study was done had smoke-free legislation or not. So half of the articles did. 10 didn't have any smoke-free legislation at the time. That doesn't mean since then it hasn't come in. And for one paper we couldn't tell because I don't think they reported the data collection, the data collection dates. Okay, so we're going to move on to the results now. As I said to you before, you can see there is a huge amount of data here. And I haven't got time, unfortunately, today to go through all of the different themes that we've identified. So this table just shows you, on the left-hand side, there are 7 core themes that we interpreted within the evidence base. And they are tabled against the 3 key areas, the a priori areas that we were interested in. So you've got the barriers, the motivators, and the enablers. And in the cells under those 3 are the sub-themes that link to the core theme on the left. So what you'll see is, for example, these 2 core themes, so social relationships and influences of others, and practicalities, cross-cut all 3 of the areas of interest. Then we've got 4 that cross-cut 2, so it could be barriers and motivators, it could be barriers and enablers. And then we've got just 1 down at the bottom, addiction and habit, that only came really through as a barrier. I'm not going to cover that today. I think we all know that tobacco is still addictive and habitual, and that's not something really novel in the data set. Okay, so I've got 7 slides of results that I'm going to go through now, and they're all set up in a very similar way. So at the top is the core theme that came from the left-hand side of that table that I've just shown you. And then on the left is whether it's a barrier, motivator, or an enabler. And then I'm going to talk about each of the sub-themes in turn. So this, for example, is about awareness of knowledge and risk. And on the right-hand side, there'll either be a summary of the interpretation of that theme, or where I've got a direct quote from one of the papers, I put a quote in to illustrate to you that particular theme. So there's a little bit of a mix. So if we start with awareness and knowledge of risk, there was a lack for some of the participants and papers of awareness and knowledge about the harms of exposing others to secondhand smoke, and that acted as a barrier. So that makes sense, because if you don't think it's harmful, why are you going to change your behaviour? And so generally, they articulated that they knew that it was harmful, but they couldn't really specify any risks, particular health-related outcomes, and the continuing risks as the child got older. And in particular, they didn't really associate risk for pregnant women. And that was something that came through quite strongly, that actually they didn't think that smoking around a pregnant woman would harm her and her baby. And so those kind of specific risks weren't very appreciated or acknowledged. Another sub-theme in here is around risk perception and acceptable risk. So what we found is that these families are constantly in a bit of a juggling act. It's a bit of a balancing act So do you expose your children to secondhand smoke or expose them to some other kind of potential risk to their health and well-being? And which is the lesser evil of those? So do you stay inside and smoke around your child and look at and safeguard them so they don't get into any trouble? Or do you potentially leave them in the house because it's cold outside, because they're doing something, to go outside to smoke and leave them unattended? And which one of those is the lesser evil? So what the participants articulated was that they were making choices that they perceived to be the rational option. And within the context that they presented it in their narratives, that they perceive it to be an acceptable level of risk. So they made choices constantly about what they thought was best for their family and about exposing their children to secondhand smoke. Quite a few of the papers presented narratives around families in particular who challenged the risk of secondhand smoke. They didn't believe that actually it was that harmful. And they used their kind of lived experience of that to try and negate the kind of messages that they were receiving from, say, healthcare professionals or mass media campaigns. So this quote just shows you, I'm not being funny, but I grew up in a house full of smoke and none of us had asthma. So actually, they are outwardly well, their children are outwardly well. So, why would I change my behaviour when I don't believe in the risks? They also thought that the media over-egged the risks that were out there and that it was intensified in the media and there wasn't any need for that. And that acted, as you can imagine, as a barrier to making their home smoke-free and maintaining it in the longer term. Now, I've covered a little bit of these strategies or harm reduction strategies that families or households might actually participate in and that they believe are effective. So things like they smoke by the window, they use air fresheners, and they believe that if you can't smell the smoke, it's not harmful, and if you can't see any evidence of smoking, that it's not harmful. So it's a bit of a lack of knowledge about the effectiveness of those harm reduction strategies that acts as the barrier here. So this particular quote saying, we have enough knowledge about protecting children from secondhand smoke. I don't smoke near the child or in the child's room. So they have put strategies in place that they don't smoke near the child or in the child's room. They think that they are protecting that child from harm. But actually we know that they're not. But they do believe that they've got enough knowledge to do that. So we're staying with the same core theme around knowledge, awareness and risk perception, but we're looking at motivators now. So this is the same sub-theme around awareness and knowledge of risk. And what you'll see as I go through the results is that some of these are the opposite sides of the same coin. So we saw in the motivator slide, in the barrier slide, that a lack of knowledge acted as a barrier, but actually for some of these participants in the papers, they did have some knowledge and they were aware and mindful of the dangers of exposing others. And that motivated them to change their behaviour. So that was in contrast to those who didn't really know that much, so didn't make any changes. I would say the predominant motivator that emerged, or we interpreted within the dataset, was around protecting other people. And most of the narratives are around protecting children, but that's because all of the papers that we found, the research questions, were about children. And we're talking to mothers, fathers, parents of children. So it's not surprising that the narratives are focused on children. But what's interesting in the top quote here is this is the healthcare professional study. And the healthcare professionals are saying that protecting children is generally seen as more important than protecting adults. We know that protecting others is a motivator, but the intrinsic level of motivation seems to vary depending on certain events. So a brand new baby in that household was really key for motivating change. So if you look at the quote here, this lady says, I go in the backyard now since I've had the baby. I went in the kitchen with the other two. So she's got an established home smoking behaviour. She's got 2 older children where she used to smoke in the kitchen. But the new baby led her to make further positive changes. So now she goes outside. One of the things, so not just about kind of events, about, say, a baby, but also if a child was diagnosed with a disease that they thought was linked to secondhand smoke, so asthma, or there was evidence to suggest ill health was exacerbated by exposure, that also acted as a motivator. So we're going to move on to the next core theme now, and this is around agency and personal attributes, and this cut across barriers and enablers. So this is around social norms, so around smoking behaviour. So in settings, this wasn't all the settings, but in some of these settings, smoking in the home and around others is normal, and it's a normalised behaviour. And smoking acts in those households and those communities as a form of social glue. And that meant it could be really difficult for household members to challenge other people's behaviours, because it was socially normal and socially acceptable to smoke and smoke around other people. And if everybody's doing that and you're going to challenge that, that can be very difficult. There was also structural factors as part of this and agency, and this resulted in a lack of agency for some subgroups within the papers that we saw. So, for example, these might be people who are living with older family members. It might be, in the Chinese setting, for example, it's culturally normal for a woman to live with her husband and his parents. And that, the cultural norm for that woman in the Chinese setting was that she shouldn't go against the hierarchy in the household, and she should be respectful of the choices of her in-laws. And that meant that she lacked agency to be able to affect change around home smoking rules. And the example here was actually a younger woman who was living with older members of her family. She said that she didn't feel like it was her place to tell them that they couldn't smoke inside. Conversely, structural factors around agency is also an enabler for some people. And this typically was leveraged in a particular role that they might have. So if we think about the hierarchy and the barriers, actually there are, if you're the head of the household, or if you are a parent, you can utilise that role, so your parenting role and your responsibility to protect your children, to give you a power base to some extent to use to enforce the rules that you want to put in place. So sometimes the structural factors allowed you to have more agency, or gave you a way to enact changes in your household. So moving on now to social norms and moral responsibility, back to motivators again. So after protecting others, one of the other core motivators was around avoiding stigma. So households or families did not want to live in a home which showed signs of smoke exposure. So you know the nicotine stains on the wall, you know you move a picture and the walls are yellow and the wall behind it's white. They were really concerned about that. And they didn't want a home that smelled of smoke. And it was the smell of smoke that was key to motivating change. Particularly, for example, they didn't want somebody to come round and to pick the baby up and the baby to smell of smoke. And they said that if people came round, they felt that it was socially unacceptable and they were stigmatised because they lived in a smoking home, and that made them want to make changes. Linked with that was being a responsible parent. This came through pretty strongly through a lot of this, and a lot of the narratives are around being a responsible parent and being morally responsible. So parents not only wanted to perceive themselves as being morally responsible, but also for others to perceive them. And smoking, in a way, didn't fit with being a morally responsible parent. So by taking smoking outside and doing something good, they felt that they would be seen as morally responsible, and that making your home smoke-free and any inconveniences that might come along with that, like having to go outside, were outweighed by their moral and caring responsibilities and their desire to protect their children from harm. And closely linked with that one was about preventing role modelling. So there was real concern that if they were seen to be smoking inside by their children, and that was a normal behaviour and socially acceptable, that those children might copy that behaviour and were more likely to become smokers themselves. And that motivated parents to want to take smoking outside, so it was less visible to the children. Okay, so this is still social norms and moral responsibilities, but this is going back to enablers. And social norms within enabling initiation and maintenance of smoke-free homes worked on 3 different levels. So it worked on a community level, on a household level, and on an individual level. So kind of having public level smoke-free legislation, to some extent, made it so that, it was normal to not smoke and normal to not smoke around children. And that kind of normalised behaviour then was reflected in the community. So if nobody smokes in your community and nobody smokes inside, it kind of enables you to make changes at home, or it facilitates changes because that's what's normal. So then you bring that into the household level, and if nobody's smoking inside and none of your peer group is smoking inside, it's easy, as you can imagine, or easier, I should say, not easy, it's easier to try and enforce those rules that you want to put in place because nobody else is doing it. And then on the individual level, there were some people who had such agency in a way that they not only made their own home smoke-free, but they were able to take those rules in a bit of a ripple effect out into their kind of peer group, into their family and social networks, and get other people to make changes to their home. So it kind of rippled out. So it kind of works down and back up. So social relationships and influence of others, this is another core theme, and this is going back to barriers now, and this is about maintaining social relationships. And certainly with a lot of the families and the healthcare professionals that I've worked with over the years, this is one of the core things that comes up every time we have a conversation. But what about my friends and my family? And in certain cultural situations, the social etiquette is that you don't question your visitor's behaviour. And this particular person is saying, when people visit, I feel really embarrassed. And I say to myself, it's just one cigarette, it doesn't matter. So they would prioritise their relationship to some extent over maintaining their home smoking rules. And in addition to kind of just the general social side of this and maintaining social relationships, lots of the women, I would say, actually receive support, be it emotional, financial, practical, childcare support from a member of the family or from friends. Typically it's her mum that offers all of that for free. And her real concern was that if she said, you can't come and smoke in my house, that support network would be withdrawn and that they wouldn't be able to maintain those social relationships. And that was all centred around whether they allowed smoking in the home or not. So that acted as a real barrier to, particularly to maintaining, because they might be able to do it while nobody else is there, but when people come, they can't maintain it. Okay, so this is the last results slide that I'm going to present today, and this is about practicality. So these are the things that facilitate or enable people to initiate and maintain a smoke-free home. And we've got a really long list of these, but these are the kind of the core ones. So this is about creating a comfortable, covered outside space for smoking. So if you've got somewhere to go, when it's chucking it down with rain, you're more likely to go outside. Having readily accessible clothing, smoking outside, that's probably a UK one because it's freezing. Incorporating smoking into routine outdoor activities, so taking the rubbish out, being in the garden. And one that was really key, and something that struck a chord with me that I hadn't really, I don't think, thought about before, was having this one unchanging rule that applies to everyone at every time, and making that really explicit and having that conversation about it and explaining the reasons why. And this is our rule and we're going to stick to it, to try and get out of that kind of fluidity and that flexibility in those rules. Okay, so I've given you a proper whirlwind tour of the results, or some of the results from our review, but we need to consider those in the context of some of the limitations that are in this evidence base. So when you do a review like this, we've got these 22 papers, but we can only tell you what's in those 22 papers that happen to meet our inclusion criteria. But it doesn't mean that actually it's better than a single primary study. It doesn't mean that there aren't limitations in that. And what we found was that the vast majority of the studies were cross-sectional and they were retrospective. So we know that home smoking behaviour changes over time. So I said to you about as a child gets older earlier on. And so you're just getting a bit of a snapshot, and then you're getting them to recall what changed over time and the triggers for that. And certainly the families I've worked with in the past tend to have quite chaotic lives. And actually trying to recall what it was that made them smoke in home again was quite difficult. So you can imagine that some of this is just kind of retrospective recall. We also found that many of the conversations that were had in, say, interviews were hypothetical rather than experiential. So some of these people had never even thought about making home smoke free or had never had a go at it. So they were, if you were going to make your home smoke free, what might help? As opposed to when you made your home smoke free, what helped? So we know in the qualitative data that experiential data are typically much richer. I think that might just reflect how hard it is to find these people, to talk to them, having spent many hours in clinics trying to identify people. So I can imagine that it's just the wider database, casting the net to get people in. The authors weren't explicit about participants' home smoking rules, of which I am guilty. So they don't tell you in the write-up or when they put primary quotes in whether that particular person had a smoke-free home or not. So sometimes it was hard to interpret the context of what they were saying because you didn't know if they got a smoke-free home or not. And many of them were focused on reducing children's second-hand smoke rather than specifically on smoke-free homes. And the smoke-free homes came out as a bit of an aside in the discussions. And that kind of reflects what's in the intervention literature, actually, around protecting children from second-hand smoke. As part of this, we've also looked to see what we think are the current evidence gaps. So we know what we've got, but we also now know what we haven't got. So we know relatively little about home smoking rules during pregnancy and in the early postnatal period. Most of the studies are with children that are older. That might reflect where you recruit them from, but actually we don't know much about pregnancy and the early postnatal period, and that's where we're going with a new study in the future. Now, surprisingly to me, 18 of the 22 papers had male participants. I thought I knew this literature pretty well before we started doing this, and I genuinely thought that it was female-focused, predominantly the mothering role, but actually there are some men in there, but you don't really hear them. You don't see them in the interpretation. We haven't seen anything that compares male and female voices within a particular paper, and that made it very difficult for us to look at gender across papers. We have tried to unpick gender to some extent, but it would be nice if there was some stronger and more data around them. We know really nothing about other adults that live in those households and about particularly vulnerable and sick adults. So we know lots about children, but we know very, very little about others. We haven't really reported or learnt from successful smoke-free households. We've got a little bit, but actually it tends to be focused on the people who haven't been able to make their home smoke-free, or because it's hypothetical discussions about if you made your home smoke-free. And I think we can learn a lot from those households, and we always tend to focus on the negative, and we should really be focusing on the positive, because I think that there are skills that we can translate and share with other people, particularly in interventions. And on that map that I showed you, there are lots of countries where we don't know what is going on, and that's particularly for those with really high tobacco consumption and where there's no smoke-free legislation. So I've got three more slides that are all implications. So we were thinking about, our aim at the beginning was to look at how we could inform policy. How would this review inform policy and intervention development in the longer term? So we put together things that came out of the review around communication and key messages, both for households and for professionals who are working with them. And I'm going to go through those first. And then I've got another slide about what we think intervention should look like. So if we look at households first, we think that it's really important that there is clarity and consistency of secondhand smoke risk messages. That includes that there's no safe level of exposure for anybody. So even if the children get older and pregnant women, they are still at risk. They need to get information on what is a smoke-free home and how do you make a smoke-free home. Because people don't know that, and they think what they're doing is good enough. And actually, sometimes it's just around education. I know education doesn't necessarily result in behaviour change, but some people are motivated by having increased knowledge. And also what the benefits of smoke-free homes are. I haven't covered that, that is in the data set. But there are some real benefits to having a smoke-free home, and people report that. And by knowing that, and that's what goes back to that successful homes, people might be able to, harness that and use that and think, in the longer term. And quite often, there is one person in the household that kind of has the burden of responsibility to be making these changes and enforcing them. But actually what we think is that all members of the household have a responsibility, and that if everybody takes a small amount of responsibility, that's less than just one person who's got all the responsibility. And we think that you're more likely, potentially, to be able to initiate and maintain a smoke-free home if everybody's got invested in some level of responsibility. So we think about professionals. We want to encourage professionals to think about secondhand smoke exposure and smoke-free homes in addition to smoking cessation. In some cultures, particularly in the UK, and I think it's probably true in Australia, smoking cessation is very prominent with professionals who are working with households or families or if, pregnant women. And certainly in the UK, people expect to be asked about smoking now. But what happens if you say, are you interested in stopping smoking? And they say no. Is that the end of the conversation? Or could we be saying to people about secondhand smoke and smoke-free homes to protect the other people in those households that they live with? Professionals need to be aware of the variation in smoking behaviours. So people do behave differently around smoking at home, and understand what a smoke-free home is. Collectively, the barriers, motivators and enablers are similar, but they will be unique to each household. And professionals with the family and with the household can identify those particular nuances in that house and help them to address that. So what about interventions and programmes? Some of these just reflect what I've covered for the key messages, but it should be smoke-free household rather than smoke-free individuals. We need to improve knowledge and understanding about risk, about what it is that is a smoke-free home, and about the benefits. And we should be using a strengths-based approach. We need to be harnessing motivation. It's not just about addressing barriers. We need to be harnessing motivation and building on positive changes. Most people have got some kind of restriction. Effective or not, they have made some kind of change. And that's a good thing. In the longer term, it's about small steps to some extent for some people to getting towards a completely smoke-free home. We also need to be aware of and supporting agency within those households. Culturally sensitive, but I think it's something that we should be looking at. And we need to be offering practical strategies. That's the one thing that I've worked with families in the past are most interested in. How do I deal with this? How do I deal with leaving my child? How do I deal with this and this? And that has got to be key. Key to any intervention is how you overcome those barriers, because it's the barriers that set you back, that break the rules and make it difficult to maintain. Okay, so that's the end of my talk. We'd welcome any comments, any comments on what you've seen or our interpretation of it. And if you've got any questions, then feel free.